I'm Dr. Anthony Maloof of Eyes and Faces and Cornea and Ocular Plastic Surgery in Sydney, and welcome to this video on DMEK versus DWEK. Now, we like acronyms, so we love these things, DMEK, DWEK. If you take the M, turn it upside down, you get W. It all sounds the same, but they're completely different. So what does it mean? I'll try and explain it in this video. Firstly, the cornea is the front lens of the eye. Touch the eye, you touch the cornea. The cornea has to be clear so you can see. Makes sense, just like the lens in your camera, the lens recording me now. What happens in a condition called Fuchs dystrophy is two basic patterns of vision loss. One is the cornea, the front of the eye swells, and one is you get a whole lot of little dots that interfere and distort your vision. You get glare, you can't look into light, and that bothers you. So it depends on what's going on as to what you complain of. Fairly simple enough. They're the basic principles of Fuchs. The next basic principle of eye surgery is operate as little as you can and only when you need to get the desired result. All makes perfect sense. Let me try and explain it to you. I've got a plastic shield here. Imagine that's your cornea and it's cloudy. That's swelling. Now imagine the cornea has little dots on the back and you get glare when you look through, like your bathroom window. That is what we call Guttati. That's another variation of Fuchs. So DMEK removes the cell layer on the back to get rid of the swelling and to get rid of all those little Guttati that give you the glare. It treats both. There is a condition where you have a lot of just the little dots on the back that give you glare, and the principle is I go and take the central part of that back of the cornea away and leave it. Now, once you do that, what's to stop the cornea swelling? And what we find is that if you just do that, the cornea can swell. That's called DWEK. You take the cornea, you peel off the central bit through which you see those little starbursts and glitterings. You hope that that will reduce the visual distortions that you get, the photophobia, the bright light, and your vision improves. Fantastic. Except it works in probably a third of cases, maybe 40%, certainly less than 50%. And when it doesn't work, what have you got to do? You go on to DMEK, where we replace the whole back, get rid of those little dots on the back of the cornea, fix up the swelling, and restore vision. I'm not a big fan of surgery with a 40% success rate. I'm just not. Not just because of the physical outcomes that aren't as optimal as we would like, but the psychological outcomes. Imagine you have a surgical procedure and things deteriorate. Mentally, it is very destructive. It's hard on your life. So I say to patients, look, I can do DWEK. It's very straightforward for me to do. It's much quicker. It's very, very predictable in the surgical outcome, but in the visual outcome, it is unpredictable. And therefore, I encourage them to just wait. When the symptoms are bad enough, I'll just do an endothelial transplant. That's DMEK. Why? It's the highest success transplant in the world. It just restores vision. My longest patients now are 17 years. Yes, you can have problems, so you only have the surgery when you want to have it done, when you want what it offers. I hope that clarifies the difference between DMEK and DWEK. And yes, I don't offer DWEK. I haven't offered it for years. I don't think it is appropriate in most circumstances, even though it can be done. My preference is for DMEK. It is more challenging, but the outcomes are better. I'm Dr. Anthony Maloof for Cornea and Ocular Plastic Surgery in Eyes and Faces in Sydney, and thanks for watching.